Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's program. Today's program is from the Special Population Series, and today's program is entitled Exercise Prescriptions for Orthopedic Injury and Rehabilitation Clients, or in our case, we could refer to those as chiropractic patients. I have a fascinating program for you today, and it's a program that I'm sure will provide invaluable information for you as you handle your chiropractic patients that have specific conditions that require your help in the rehabilitation of those conditions. And let me just take a moment to introduce myself to you. This is Dr. Perry Carpenter. I'm a chiropractor. Been a chiropractor for approximately 28 years now. I graduated from Palmer West College of Chiropractic. And throughout the years, I've taken many different types of continuing education courses. And I list for you here some of the courses that I've completed that qualify me to speak on today's topic. And specifically, I'm going to be making extra reference today to materials derived from the National Strength and Conditioning Association, of which I'm a member. I hold two credentials with the NSCA. I hold the Certified Strength and Conditioning Specialist credential and also the Certified Special Population Specialist credential. And today's material is largely based on ideas, references, and concepts about rehabilitating and treating persons who qualify as special populations. And today we're talking about that group of special populations that we find in the chiropractic practice, and that is people who have healthcare issues. Specifically, today we're talking about injuries and issues with the musculoskeletal condition. So today's program is about injury, orthopedic, and rehabilitation patients. And those certainly qualify as special populations. And those are certainly people that have special and unique needs perfectly suited to the work that we do as chiropractors. So I'm going to be supplementing chiropractic material today with additional material derived from the exercise sciences. And I will be quoting some references from the National Strength and Conditioning Association. References for today's program are many, and draw your attention to a couple of textbooks from the National Strength and Conditioning Association. I'll be presenting information from the Essentials of Personal Training and also the Essentials of Strength Training and Conditioning. I'll also draw upon material out of Lippincott's Primary Care Orthopedics 2nd edition. I'll refer to Yoakum and Rowe Essentials of Skeletal Radiology, specifically when we get into a discussion later on the rehabilitation of spondylolisthesis and spondylolysis. I'll be drawing on some physical examination procedures from the Fundamentals of Musculoskeletal Assessment Techniques. That's a fabulous textbook by Palmer and Epler, a couple of physical therapists. I'll make also a brief reference to the AMA Guide's 5th edition, and those of you that are qualified medical evaluators, you'll recognize those references. And then I have a couple of specific references for you relating to the shoulder and the lumbar spine. And I chose and selected these references for a couple of different reasons. Number one is they relate exactly to topics that we're going to be discussing, specifically related to the lumbar spine and specifically related to the shoulder. And also because each of these articles illustrates some general principles that are extremely important principles that we understand regarding injuries and rehabilitation in general. And I'm going to make early references to each of these principles early in the program. And then when it comes time, when we get to the lumbar spine section and when we get to the shoulder section, I will reiterate these principles by drawing upon these references, specifically as relates to the region that we're considering, whether it be the shoulder or the lumbar spine. And I know you're going to find these references to be fascinating, and these are some principles that are illustrated in these references that you can rely on and that you will rely on in your practice from now to forever. Well, what about lumbar disc injury? What can we do for those patients who present to our office with a diagnosis of a bulging disc or a herniated disc or a disc protrusion or a disc prolapse, whatever they call it nowadays? What can we do for these particular patients? Well, let's go over some of the anatomy involved and some of the physical examination findings involved with lumbar disc injury, and then we'll get into the specific exercise and movement recommendations for these cases. Remember that the intervertebral disc is composed of two components. It's composed of the nucleus pulposus and then also the annulus fibrosus. The nucleus pulposus is a gelatinous substance that absorbs axial loading. And the purpose of the nucleus is to transfer axial energy from axial loading circumferentially distributed to the annulus fibrosus. Now, the annulus fibrosus is made of fibrocartilage, which is surrounded by fibrous connective tissue, thick, dense, and regularly arranged collagen fibers. Well, the load that is imposed upon the nucleus pulposus, the axial loads that come down the center of the vertebrae, these are converted into hoop stresses, which are distributed circumferentially throughout the annulus fibrosus. And it's the conversion of axial loads into hoop stresses that allows the disc to maintain its height and maintain its function under even tremendous axial loads. Now, problems can arise when degenerative changes over time or even an acute single event trauma cause injury to the fibers of the annulus fibrosus, and nuclear material begins to extrude out through defects in the annulus. And generally these defects are located slightly lateral to posterior, where the posterior longitudinal ligament is thinnest. And ultimately, over time, either mechanical pressure and or chemical irritation of this extruded nuclear material leads to typical signs and symptoms that we see in the chiropractic office, which we refer to as lumbar radiculopathy. Remember, the term radiculopathy means injury to lumbar spine nerve roots. That's differentiated from the term myelopathy, which refers to injury to the spinal cord. Well, in the lumbar spine, we don't have any spinal cord because the spinal cord typically ends at around the L1 level of the spine. So by the time the spinal cord ends, all we have left are the nerve roots that come down in the cauda equina and then leave at the various levels of the lumbar and sacral spine. And irritation of these nerve roots, either within the spinal canal or exiting through the neuroforamen, we refer to as lumbar radiculopathy. Now, typical symptoms that our patients are going to present to in the presence of bona fide radiculopathy is they will complain of back pain, of course, and then either unilateral or, less commonly, even bilateral leg pain. They'll complain of some sensory disturbances, and they'll report any one or any combination of the dysesthesias Dysesthesias could include numbness, tingling, burning, prickling, itching, tickling, uh, uh, heat-like sensations. Any of the dysesthesias will be distributed dermatomally throughout the involved lower extremity. Typically, our patient will report that pain is worse with sitting because of the axial loading imposed upon the lumbar spine. Generally, pain is relieved with either standing or with lying down, especially in those postures wherein they can maintain flexion of the knee, thereby decreasing tension on the lumbar spine nerve roots. Lumbar disc injury is most common at L5-S1 and then secondarily at L4-L5. And when the nerve roots become involved, the disc injury most commonly affects the traversing nerve roots, but occasionally affects the exiting nerve roots. Remember, in the lumbar spine, the nerve roots exit the spine below the named vertebra. So in this example, this is the L4 vertebra. The L4 nerve root leaves below the pedicle of the L4 vertebra. However, the L4 spinal nerve is not affected generally by a disc bulge at L4, L5. This disc bulge would affect the traversing L5 nerve root. However, if that disc bulge is a high disc bulge and it migrates superiorly, it can affect the exiting L4 nerve root. But generally, because of the anatomy, the disc bulge would affect the traversing nerve roots rather than the exiting nerve roots. Similarly, at the L5-S1 level, it's the L5 nerve root that comes out beneath the pedicle of L5, which is right about here. So the L5 nerve root is typically not involved with a disc bulge at L5-S1. This affects the traversing S1 nerve root, traps it and irritates it both mechanically and chemically prior to its exit between the S1 and S2 segments of the spine. On physical exam, we're going to characteristically see some pathognomonic findings that we typically associate with lumbar radiculopathy. And specifically, we've come to rely on the root tension signs, or these so-called sciatic nerve stretch tests. So let's talk about some of the different sciatic nerve stretch tests. And before we get into those, I just want to give you a little bit of heads up on the root tension signs and sciatic nerve stretch tests in general. And that is that sciatic nerve stretch tests were designed, and typically we interpret them as tests of involvement of irritability of the lumbar spine nerve roots. And we assess the reproduction of the symptoms when the nerve roots are tensed. Now, it's important to remember that the spinal nerve roots are not the only structures that are provoked by sciatic nerve stretch tests. So what are some of the other structures that can be provoked by some of these sciatic nerve stretch tests? Well, how about the vertebral facets? How about the sacroiliac joints? How about the hip joints themselves? How about the hamstring muscles? How about the connective tissues in and around all of these articulations? We need to remember that one or multiples of these other structures can be the source of symptoms or at least influence the systems. And so therefore, it's our job as the examinee to conclude and to decide which of the structures is responsible for the production of pain. In other words, sciatic nerve stretch tests can give us false positive findings for lumbar radiculopathy when in fact the pain could be produced by other structures. And I'll give you some ideas and some maneuvers that we can rely upon to sort out some of these other strokes. So let's talk about straight leg raise testing. With straight leg raise testing, you're all familiar with this maneuver. The subject lies supine with the non-test limb positioned in extension and resting on the table. The examiner passively raises the test lower limb, keeping the hips slightly abducted and internally rotated and the knee fully extended. Now, a positive finding for straight leg raise testing is a reproduction of symptoms in either the lower back or along the distribution of the sciatic nerve. Now, sciatic nerve tension is greatest between somewhere between 20 and 70 degrees of hip flexion. So a positive test for sciatic nerve involvement will generally occur prior to 70 degrees of hip flexion. And many times you'll have examinees who report lower back and leg pain, and yet their leg is up at 90 degrees of hip joint flexion. And this, you could conclude, is not due to sciatic nerve tension, but rather is due to mechanical or joint irritation. So here's a diagram of an examinee going through straight leg raise testing. Straight leg raise testing by itself can produce pain from a variety of sources, including muscle pain, ischial bursitis, disc injury, of course, even hamstring tightness, in addition to what we're considering here involving the disc injury. So a couple ideas in order to sort abilities. Remember that sciatic nerve tension is greatest between 20 degrees and 70 degrees. And some anatomy textbooks and some authorities argue that that range of motion, this 50-degree range of motion, is actually even less. Some references state that sciatic nerve tension does not begin until the hip is flexed at least 35 degrees. So that would provide only a 35-degree arc through which the sciatic nerve roots become tensioned. So, therefore, reports of pain and reproduction of symptoms at angles less than, say, 20 to 35 degrees could be considered a false positive finding. Similarly, reproduction of symptoms at angles greater than 70 degrees would also be considered a false positive finding, at least for lumbar radiculopathy. One of the tests that we can use to sort out some of these potential confounders is the popliteal compression test. And the popliteal compression test is another testing procedure designed to traction and tense the sciatic nerve roots. Remember, the sciatic nerve roots include L4, L5, S1, S2, and small filaments even from S3. So with the popliteal compression test, we lower the involved leg a few degrees below the point at which the examinee reports symptoms with the straight leg raising test. So we take the leg up to the point at which the examinee reports pain, and we lower it a few degrees. Then, using our thumbs, we apply compression to both the medial and the lateral aspect of the popliteal fossa, thereby tractioning and tethering the sciatic nerve as it branches out to become the common peroneal nerve and the tibial nerve. So applying compression to the popliteal fossa helps to tether the sciatic nerve and should provoke symptoms with a lesser degree of straight leg raise angle, thereby implicating the sciatic nerve roots as the cause of pain rather than implicating the hip joint, rather than implicating the hamstring muscles, rather than implicating the sacroiliac joint. So this is a confirmatory test that we can use to corroborate and validate the findings of our straight leg raise testing. Another maneuver that we can use is the Bragard's maneuver, also another one of the sciatic nerve stretch tests. With the Bragard's maneuver, we perform this similar to the popliteal compression maneuver in that we lower the straight leg raise angle to a few degrees below which the examinee reports pain, and then we further traction the sciatic nerve roots by dorsiflexing the ankle. So, for example, if the examinee reports pain with straight leg raise testing at, say, for example, 50 degrees of hip joint flexion, we would then lower the leg to a measurement of approximately 45 degrees of hip joint flexion, and then dorsiflex the ankle to reestablish the traction on the sciatic nerve roots. Positive tests for Bragard's maneuver would include reproduction of symptoms along the distribution of the sciatic nerve. Now, for those of you that are involved in medical legal work, it's worth mentioning what would be considered a true positive objective finding for sciatic nerve root irritation. Well, whether we're considering the straight leg raise testing, the popliteal compression testing, or Bragard's maneuver, a true positive objective finding would be considered some attempt by the examinee to reduce traction on the sensitized and sensitive sciatic nerve roots. So, for example, in this demonstration here, the examiner has elevated the leg using the straight leg raising maneuver. He's then dropped the leg down a few degrees until the symptoms resolve, but then he's attempted to re-stimulate the symptoms by dorsiflexing the ankle. Now, in the presence of true bona fide radiculopathy, this examinee is going to have a pain and an apprehension response. And that pain and apprehension response can be manifest in at least a couple of different ways. One way that it could manifest is that the examinee then quickly plantar flexes the ankle in an effort to relieve the imposed stretch imposed by the examiner. Another positive objective finding and a true objective finding would involve a flexion of the knee or a withdrawal of the knee in order to reduce traction on the nerve roots. And a third possibility for a true objective finding would be the examinee quickly forcing the leg down closer to the table, thereby reducing the hip flexion angle. All of these three maneuvers would quickly relieve imposed stretch on the sciatic nerve roots. And for those of you that are involved with medical legal work, this would be considered a true positive objective finding. Simply a report of pain along the distribution of the sciatic nerve does not constitute a true positive objective finding. Okay? I hope that helps those of you that are involved in medical legal work. Other root tension signs that we won't go into here, but that we can use include the crossed straight leg raising maneuver. This is a maneuver that gives us some indication as to the location of the disc herniation, whether that herniation be straight lateral or more centrally or medially located. Another maneuver that's in common practice, which I recommend that you use, is the slump test, which progressively tractions the dura from above down versus from below up, such as these other maneuvers that we've been talking. Finally, for sciatic nerve stretch tests, again, the true positive objective finding for sciatic nerve stretch tests involves some attempt by the patient to relieve traction on the sciatic nerve root, because in the presence of true and bona fide radiculopathy, no examinee is going to allow you to painfully traction their hot and inflamed sciatic nerve roots across a disc bulge. They simply won't do it because the painful stimulus invokes or evokes a flexion withdrawal reflex from the examinee. It's a form of pain withdrawal. And the pain withdrawal reflex associated with sciatic nerve stretch tests involves any type of reaction by the examinee that serves to reduce traction on the lumbar spine nerve roots. One of the more commonly observed reactions from the examinee is what's known as Neary's bowstring sign. And Neary's bowstring sign can be evident with the examinee both supine and with the examinee standing. So Neary's bowstring sign is an observation of flexion of the knee on the involved side as the hip flexion angle increases. Now, this is an involuntary, unconscious, and reflexive reaction in an effort to relieve tension on the lumbar spine nerve roots. Often this can be detected as an inability to perform the heel walk maneuver due to increasing tension on the sciatic nerve roots, because as we walk on our heels, that involves a dorsiflexion of the ankle, and it simulates to some extent the Braggart's maneuver. So this would be a validity finding for sciatic nerve root irritation. Now, for those of you that do medical legal work, the absence of a reflexive bowstring sign in the presence of reports of radiculopathy symptoms could be considered a non-physiologic or an inconsistent physical exam finding. So with your radiculopathy cases, I want you to quicken your thinking to the presence of true bona fide objective findings manifest in the form of withdrawal. Here it shows the examinee standing, and in the presence of a bona fide radiculopathy, no examinee in the world is going to simply bend over and touch their toes and traction their sciatic nerve root to the point at which it causes pain. There will be a reflexive withdrawal response in the form of flexion of the knee on the involved side. So pay attention for Neary's bowstring sign. Okay, so we now know how to identify the presence of bona fide disc injury and bona fide cases of lumbar spine radiculopathy. What do we do with these patients? Well, of course, we administer chiropractic treatment, the purpose of which is many-fold, including to restore normal motion and normal alignment and normal mechanical function of the involved vertebrae. Well, what about exercise recommendations? Well, with lumbar spine disc injury and radiculopathy, we have to be very careful, because any exercises or any maneuvers that load the lumbar spine in anything but the neutral position can cause exacerbation and worsening of the disc injury. So loaded lumbar flexion, loaded lumbar extension, loaded lumbar rotation movements would all be contraindicated. Because of the tractioning effect on lumbar spine nerve roots, any types of stretches that involve flexion of the lumbar spine, especially involving full extension at the knee, those would be contraindicated. And this is something that you need to advise your patients of in advance. You can simply assume that your lumbar spine disc and radiculopathy patients are trying to relieve their own symptoms by stretching out their hamstring muscles and stretching out their lower back. And in effect, what they're doing is they're recreating the straight leg raise maneuver and tractioning those lumbar spine nerve roots and progressively making the condition worse. Now, you can anticipate this in advance because for the patients, it feels like the lower back and the leg needs to be stretched out. To hear the suggestion from you to not perform lumbar flexion stretches, especially with a straight knee, comes to our patients as counterintuitive. This is not something that they would consider because it feels like it needs to be stretched out. It feels like the sciatic nerve is being drawn up, like it's being tensed, like it's tight, like it's drawn up. And it feels like it needs to be stretched. When in actuality, this only worsens the situation by continually tractioning the lumbar spine nerve roots over an inflamed, hot, and bulging lumbar spine disc. So you can caution your patients about this in advance and assume that they're already doing this. And if you question them about this, they will admit that yes, indeed, they've been trying to stretch this pain out of their buttock and the back of their leg, but it cannot be done. Okay. In addition, other flexion maneuvers such as sit-ups, such as squats, such as rowing movements, either seated rowing movements or bent over rowing movements, deadlift exercises, bicycle riding where the patient is bent over the handlebars, or any other flexion maneuvers in either resistance training or aerobic classes are going to be contraindicated. Further, any type of maneuver that increases the intra-abdominal or intrathoracic pressure by way of the Valsalva maneuver would be contraindicated. And this makes sense, and we're all familiar with those patients who simply say, all I did was sneeze, and I got pain in my back, or all I did was cough, and I got this sharp pain in my lower back. Sometimes they'll say, when I sit down on the toilet and I bear down to go to the toilet, I get this sharp pain in my lower back and leg. And these are all different manifestations of the Valsalva maneuver, which increases intrathecal pressure, intra-abdominal pressure, and will quickly aggravate symptoms. So these are some exercise cautions and contraindications. Well, so what can we do? Well, first and foremost, we want to maintain other parts of the body that are not involved in the painful symptoms. So while the patient is undergoing chiropractic treatment for the lumbar disc injury, we want to make sure to maintain their cardiovascular fitness. We want to make sure to maintain their upper extremity strength. And they can do all the upper extremity strengthening exercises in the world as long as none of the exercises load up the lumbar spine in the positions that we discussed on the previous slide. So they can do biceps work, they can do triceps work, they can do chest work, they can do lat work, they can do trapezius work. As long as it does not load up the lumbar spine, they can blast those other areas to maintain fitness in those areas while they're recovering from the lumbar spine injury. They can do exercises for the most immediately adjacent articulations as long as those exercises do not cause pain and do not load up the lumbar spine. So they can do knee extension exercises. They can do knee flexion exercises. They can do ankle dorsiflexion and ankle plantar flexion exercises, and any exercises for adjacent articulations as long as they do not exacerbate lower back pain. Finally, we want to implement spinal stabilization exercises similar to the ones that we described in the previous section relating to rehabilitation for lumbago. It's important that with lumbar spine disc cases, the spine be maintained in a neutral position, neither in a position of flexion nor in a position of extension. We want the lumbar spine and the pelvis to remain in pelvic neutral. Finally, we want to implement neuromuscular and proprioceptive balance exercises that involve stabilization and proprioceptive challenge to the individual segments of the lumbar spine. And we went over several of those in the prior section.